Hey guys, welcome and welcome back to my channel. This is Dr. Prasanjit Das, currently JR1 in the Department of Pharmacology, AIMS Kalyani, and today I am back with another video. So in today's video, I am going to present my seminar that is on pharmacokinetics, that is the principles of drug transport and absorption. So in this seminar, we are actually mainly covering about the drug transport and the absorption. So we are not going to discuss in detail about the distribution, metabolism and excretion of the drugs. So in today's seminar, I will be covering several topics, that is the definition of the pharmacokinetics and definition of absorption, then the different transport mechanism of the drugs, then absorption of the drugs from various sites in the body, then methods for delaying and facilitating the absorption of the drugs, bioavailability, bioequivalence, then measurement of bioavailability, and then finally the factors which are influencing the absorption of the drugs and hence influencing the bioavailability of the drugs. Now coming to the first slide, so the definition of pharmacokinetics and absorption. So what is pharmacokinetics? So pharmacokinetics is basically the quantitative study of the drug movement in, through and out of the body. So it includes several processes, that is absorption, then we have distribution, then we have metabolism, and finally we have excretion, that is ADME. So pharmacokinetics deals with these four processes, that is absorption, distribution, metabolism and excretion. So in short, it deals with what the body does to the drug, and absorption is actually the movement of the drug into the bloodstream from its site of administration, unless the drug is purposely injected directly into the bloodstream, where the absorption process is completely bypassed, because here the drug directly enters into the blood. Now coming to the biotransport. So whenever a drug is administered, it has to reach the site of action, for which it has to cross the biological barrier, that is the cell membrane, which is made up of the phospholipids, that is the lipid bilayer cell membrane. So the movement of the drugs across this biological barrier, that is the cell membrane, is called as biotransport, and the mechanism of this transport is called as the transport mechanisms. So biotransport has to occur at every stage of pharmacokinetics, that is at absorption, distribution, metabolism and even excretion. So coming to the different major transport mechanisms which are present for the transport of the drugs. So first we have passive transport, that is passive diffusion, which is also known as the simple diffusion. Okay, so here the drug moves from higher concentration to lower concentration. We will be discussing each of these in the subsequent slides. Then we have the carrier mediated transport, under which we are having two categories, that is the facilitated diffusion, and then we have the active transport. Active transport is further classified into primary active transport and secondary active transport. Then we have pinocytosis and phagocytosis, which are the types of actually endocytosis, and then we have finally filtration. So coming to the first one, that is the passive diffusion. So it is basically a transfer process in which the drug molecules pass through a biological barrier, that is the cell membrane, from the phase of higher concentration to the phase of lower concentration, without requiring any expenditure of energy by the biological system. So it is a process in which there is no expenditure of energy, and there is the movement of the drug molecules from the higher concentration to the lower concentration. So drugs that are highly lipid soluble will diffuse rapidly, whereas the less lipid soluble, that is the ionized drugs, will diffuse slowly. So for partly ionized drugs, that is either weakly acidic or weakly basic drugs, the passive diffusion depends upon the degree of ionization of that particular drug. So if the drug is more ionized, then it will be diffusing slowly, whereas if the drug is less ionized, it can easily diffuse through the hydrophobic lipid bilayer. So examples of weakly acidic drugs include phenytoin and phenobarbital, and then example of weakly basic drugs include morphine, amphetamine and chloroquine. Then coming to the Henderson-Hasselbalch equation. So this is very important. That is, the degree of ionization of a partly ionized drug depends on the pH of the medium. And Henderson-Hasselbalch equation explains the relationship between the degree of ionization and the pH of environment in which the drug is present. So basically, this equation helps us to understand the relationship between the pH of the medium and the degree of ionization of the drug which is present in that particular medium. So here it is given as the following, that is the equation is pKa of acid, that is the dissociation constant of the drug, is equal to pH plus log of concentration of the non-ionized acid by concentration of the ionized acid, and similarly for pKa, that is base, pH plus log of concentration of ionized base by concentration of non-ionized base. So it is different for acid and base. In case of acid, non-ionized acid is in the numerator, whereas the ionized acid is in the denominator, whereas in case of base, it is the ionized base which is present in the numerator and non-ionized base which is present in the denominator. So this equation will help us to understand the relationship between the pH of the medium and the degree of ionization of the weakly acidic or the weakly basic drugs. That is, it finally affects the absorption of the drug through the lipid bilayer. So what are the implications of the Henderson-Hasselbalch equation? So according to Henderson-Hasselbalch equation, we can say that stronger the acid or weaker the base, the lower will be its pKa value. This you can understand by substituting the values in that Henderson-Hasselbalch equation which we have already mentioned. So weakly acidic drugs like aspirin, phenytoin and barbiturates, they remain predominantly non-ionized in acidic medium and are better absorbed from the places like stomach. This is because the stomach is having the acidic medium, so there these drugs which are weakly acidic in nature, they will remain in non-ionized form, and as a result they will be easily crossing the lipid bilayer. Next is weakly basic drugs like morphine, diazepam and amphetamine. They remain predominantly non-ionized at an alkaline pH. Okay, so these are thus better absorbed from intestine. This is because in intestine we are having an alkaline pH, so in that case these drugs, that is morphine, diazepam and amphetamine, they will remain non-ionized, and as a result they can easily cross the lipid bilayer. But however, the net absorption of any drug is always more from intestine, irrespective of the type of the drug, whether it is weakly acidic drug or weakly basic drug. This is because of the shorter stay of drug in stomach and a limited surface area of the stomach compared to intestine, because in intestine the drug stays for a longer duration of time and intestine has got a larger surface area because of the presence of the villi. So always the net absorption of any of the drug which is given orally will be maximum from the intestines. Now continuing with that, so if the pKa of the drug is equal to the pH of the medium, then if we substitute this in the Henderson-Hasselbalch equation, it will be found that the drug will be 50% in ionized form and 50% in non-ionized form in that particular pH, that is in that particular medium. And strongly acidic or basic drugs and quaternary ammonium compounds, they remain predominantly ionized at all pH and are therefore poorly absorbed from GIT. So this is also an application of Henderson-Hasselbalch equation, that is the quaternary ammonium compounds and the strongly acidic or the basic drugs, that is the strong electrolytes, they are actually remaining ionized almost always in all the types of pH, and therefore they are poorly absorbed from GIT. Now coming to the phenomenon of ion trapping. So conditions that favor the ionization will actually restrict the translocation of the weak electrolytes, that is weakly acidic or weakly basic drugs, since the proportion existing as the diffusible form is low. So this leads to a phenomenon which is called as ion trapping. That is, if the weak electrolyte, that is weakly acidic drug or the weakly basic drug, is converted into an ionized form, then it will not be easily diffusing through the cell membrane. As a result, it will be accumulated in that particular cell, which will lead to a phenomenon that is called as ion trapping, because the ionized form is trapped in that particular cell. So example is like when a weakly acidic drug, that is aspirin, which easily crosses the gastric mucosa. This is because in stomach the pH is 2, that is acidic, and this is also a weakly acidic drug, so it can easily cross the biological membrane, but it gets reverted back to an ionized form within the cell, that is in the gastric cell where the pH is of 7. This is because of the high pH that the weakly acidic drug gets converted into an ionized form, and as a result now this ionized form slowly passes to the extracellular fluid, because now it is ionized, so it cannot easily cross the biological barrier. So this ion trapping is possibly contributing to the gastric mucosal damage which is caused by aspirin. This is because the aspirin gets trapped in the gastric cells as it is being converted into an ionized form inside the gastric cells, so it cannot cross the gastric cells easily, leading to gastric mucosal damage. So this is one application, or this is one implication of ion trapping, that is the ionized drugs are not able to diffuse faster as compared to the non-ionized drugs. Now coming to the next mode of transport, that is the carrier mediated transport. So polar drugs, that is the ionized drugs, cannot cross the membrane by passive diffusion. So they are transported with the help of carriers, that is basically proteins which are present in the membrane. So the drugs bind with the carrier, and the drug carrier complex is formed, and then this complex crosses the membrane, and finally the carrier dissociates from the drug. The carrier is then either sent to the original site from where it was bound to the drug, or it is being eliminated and then resynthesized again. So we have two types of carrier mediated transport, that is facilitated diffusion and active transport. So in facilitated diffusion we don't need expenditure of energy, whereas in case of active transport we need expenditure of energy. So that is the difference between facilitated diffusion and active transport. So this is the process of carrier mediated transport, that is the drug binds to the carrier, then drug carrier complex is being formed, and then it crosses the membrane and reaches the other side where it is getting dissociated from the carrier, and finally the carrier is again sent back to the original site, or it is eliminated and resynthesized again. So two different types includes facilitated diffusion and active transport. Now what is facilitated diffusion? So here the carrier moves a drug along its concentration gradient, that is from higher concentration to lower concentration. It is just similar to the simple diffusion, but here it is carrier mediated. So since the drug moves from a higher concentration to lower concentration, so there is no energy required in this process, and it is a capacity limited process. This is because the carriers get saturated, so as a result it is leading to a process which is a capacity limited process. That is, the rate of diffusion depends upon the binding availability of the drug to its carrier and is limited by the availability of the carriers. So if the carriers are completely saturated, then the process will stop. So that is the reason why you can see here in the graph, that is the drug concentration and rate of absorption. Initially the rate of absorption increases in case of facilitated transport, that is facilitated diffusion, and finally it becomes a plateau. This is because all the carriers are saturated, and the same holds for active transport also. Now two drugs with similar physicochemical characteristics can actually compete for the carrier, and hence they can affect the absorption of each other. So if we have two drugs which are being transported by the same carrier, that is in the facilitated diffusion, then each of them can actually affect the absorption of one another. So that is the key point which we need to know when two drugs are being transported by a same carrier. And then in case of simple diffusion, you can see the graph is straight, linear graph, and it keeps on going. And it keeps on ascending. This is because there is no saturation, because there is no involvement of carrier proteins in this simple diffusion. So the drugs which are actually transported with the help of facilitated diffusion includes antiviral drugs, then we have anti-metabolite, anti-cancer drugs, vitamins like riboflavin, thiamine, and vitamin B12. So these are the drugs which are actually being transported with the help of facilitated diffusion. Now coming to active transport, which is also known as uphill transport. This is because here the transport of the molecules occurs from a lower concentration to higher concentration, that is against the concentration gradient. So it is an energy dependent carrier mediated transport of drugs against the electrical and the concentration gradient, that is from the lower concentration to higher concentration. So the energy which is required is actually generated by the help of the membrane ATPase. So membrane ATPase is responsible for producing the energy which is required for this transport. And it is also a capacity limited process, just like the facilitated diffusion. This is because it also depends on the availability of the carrier. So the curve will be similar to that of the facilitated diffusion. That is, initially the curve will increase with the concentration of drug, then finally it will reach a plateau, which is seen in case of facilitated diffusion also. So if two drugs have similar physicochemical properties, then again just like facilitated diffusion, here also they will compete for the carrier and then they will affect their absorption. So active transport can be blocked by reducing the ATP levels, because it is a energy mediated process. So if we reduce the levels of ATP, then it will block active transport, that is by giving agents like sodium cyanide, then we have sodium fluoride and 2,4-dinitrophenol. So these are the drugs which reduces the ATP levels. So these are the components which reduces the ATP levels, that is sodium cyanide, sodium fluoride, and 2,4-dinitrophenol. So this will actually hamper the active transport of different drugs. So the drugs which undergo active transport includes 5-fluorouracil, then we have sympathomimetic amines, choline, etc. and then depending upon the driving force, active transport is further divided into two categories, that is the primary active transport and the secondary active transport. So in primary active transport, here the biotransport of drugs is directly coupled with ATP hydrolysis for deriving the energy. It is usually carried out by ATP binding cassette group of biotransporters, example P-glycoprotein, that is PGP. Then also ABC transporters cause unidirectional efflux of many drugs like the antibiotics, anti-cancer drugs, digoxin, anticonvulsant, HIV protease inhibitors. So this is actually detrimental for some of the therapeutic agents, like if the antibiotics are being effluxed, so it becomes a way by which the microbe is showing the resistance against the antibiotic treatment. So this was about the primary active transport. Now coming to the secondary active transport, that is here one ion or solute like X supplies the driving force for the transport of the other ion or solute, that is the solute Y. So here you can see the primary active transport, that is directly the hydrolysis of ATP into ADP plus PI, that is inorganic phosphate. Then we have secondary active transport here, as you can see here. So a symporter is an example of secondary active transport, that is it transports X and Y in the same direction, example Na plus K plus 2Cl minus symporter. Then an antiporter transports the two molecules, that is X and Y, in opposite direction, example Na plus H plus exchanger. So these mechanisms are not directly linked to ATP hydrolysis, that is the transport of one ion is linked to the ATP hydrolysis, whereas the other ion transport occurs because of the movement of the first ion. So this is the reason why it is called as secondary active transport, that is it is not directly linked to the ATP hydrolysis. One molecule is linked to the ATP hydrolysis for its transport, and the other molecule gets transported because of the driving force of the first molecule. So this is about the secondary active transport. Now here you can see the pictorial description and of the passive transport, that is the downhill transport, and then we have the active transport, that is the uphill transport. So here we have passive diffusion, that is drug getting transported from higher concentration to lower concentration. Then we have facilitated diffusion, here also drug gets transported from higher concentration to a lower concentration with the help of a carrier protein. Then in case of active transport, we can see the different methods. So here having the primary active transport, that is with the help of ATP hydrolysis, the drug is being transported from lower concentration to higher concentration. Then we have symport and antiport, that is the transport of molecules in the same direction, that is what we call as symport, and then the transport of the molecules in the two opposite direction, that is what we call antiport. So these are the examples of secondary active transport. So now coming to the membrane transporters, which are responsible for transporting the drug molecules. So these are usually the proteins that control the therapeutic response or toxicity of the drug through their ability to either influx or efflux the drug from a cell. As I have already mentioned, these can either influx or efflux the drug, so hence it can actually affect the therapeutic response and toxicity of the drug. So they can control the absorption process, they can control the distribution and also the elimination of the drugs. They are present in different areas like intestine, kidney, lungs, liver and blood-brain barrier. So we have two superfamilies of these membrane transporters for the drugs. They are ABC and SLC, that is ATP binding cassette superfamily of biotransporters and solute link carrier superfamily of biotransporters. So these two are the most important ones, that is ABC and SLC. So this we need to keep in mind. So first coming to the ABC superfamily of biotransporters. So they are involved in primary active transporter, as I have already mentioned, example is P-glycoprotein, and hence they are coupled with ATP hydrolysis and energy generation out of it. So there are 7 subclasses of ABC superfamily of biotransporters, that is ranging from ABCA to ABCG, which are encoded by 49 genes. So most important example for these biotransporters includes P-glycoprotein, which I have already mentioned, which is also known as MDR1, that is multi-drug resistance 1 gene, and multi-drug resistance 1 gene is one out of the mentioned genes which are responsible for actually mediating the multi-drug resistance in several bacteria. That is, the P-glycoprotein is responsible for causing the efflux of the antibiotics leading to antibiotic resistance. Now continuing with that, so in ABC transporters we have two major components. First is a nucleotide binding domain and then we have a transmembrane domain. So here you can see the nucleotide binding domain, and then we have the transmembrane domain. So what happens is nucleotide binding domain binds to ATP, and transmembrane domain involves in the substrate, that is the drug recognition, and finally the translocation process. So here you can see the drug molecule. So first what happens is substrate recognition by TMD occurs and ATP binding to NBD occurs, that is substrate recognition occurs and then ATP binding to the NBD, that is the nucleotide binding domain, and this leads to the ATP binding leads to actually the outward facing conformation of the ABC transporter, as you can see here, and then the drug is removed outside. Finally, the dissociation of the hydrolysis products of ATP, that is ADP plus for inorganic phosphate occurs, and finally this leads to an inward facing conformation of ABC transporter, that is back to its original position. As you can see, the position which was initially present, finally the final position is also the same. So this is a mechanism by which the drug molecules are transported with the help of the ABC superfamily of biotransporters, which comprises of a transmembrane domain and a nucleotide binding domain. Now coming to the next group of biotransporters, that is solute link carrier superfamily of biotransporters. So SLC superfamily of biotransporters are involved in facilitated diffusion and secondary active transport, that is transport of two different molecules. One is related to ATP hydrolysis and the other one is related to the transport of the previously mentioned ion. So there are 65 SLC families which are encoded by 458 genes. The prominent SLC transporters are neurotransmitter transporters, like for the neurotransmitters like serotonin, then norepinephrine and dopamine. Other SLC transporters include GLUT, that is glucose transporters, then we have cholesterol transporters, then sodium glucose co-transporters, that is SGLT2 transporters, then we have folate transporters, then we have heme transporters. And there are several human diseases which are linked to the improper functioning of these SLC transporters, which we will be discussing in the next slide. So these are the different SLC transporters which are implicated in several human diseases. So first is sodium glucose co-transporter. It is implicated, it is affected in case of glucose glucose malabsorption. Then we have H plus coupled metal ion transporter, which is affected in case of hereditary hemochromatosis. Then acetyl CoA transporter in case of congenital cataract, riboflavin transporter in case of riboflavin deficiency, and folate transporter in case of folate malabsorption. So these are the different SLC transporters which are implicated in the following human diseases. Now coming to the next mode of transport, that is endocytosis, which is having two variations, that is pinocytosis and we have phagocytosis. So endocytosis is nothing but it involves the cellular uptake of an exogenous molecule or exogenous complexes inside the plasma membrane derived vesicles. So with the help of the plasma membrane derived vesicles, it is taking in the exogenous molecules which can be the drug. So it can be of two major categories, that is pinocytosis and phagocytosis. Both these processes require expenditure of energy, but the drug doesn't need to bind to a carrier here, unlike facilitated diffusion and active transport. So in case of active transport, what we have learned is that there is transport of the drug with the expenditure of energy with the help of a carrier protein, whereas in case of pinocytosis and phagocytosis, there is again expenditure of energy in the form of ATP, but there is no requirement of a carrier protein here. So first is pinocytosis. As you can see here, this is a pictorial representation of pinocytosis. In this process, the cell engulfs the solution in which the drug is present. So its stages include the following. First is the solute which is present in the solution are first trapped in the invaginations of the membrane surface. So these are the invaginations of the membrane surface, that is invaginations of the plasma membrane. Then the invaginations fuses around and completely enclose the solution to form a vesicle. So this is the vesicle, that is invaginations fuses around, and now the solution is present inside the vesicle. Later on, the vesicle is pinched off, and then this vesicle is in the interior of the cell. So once the vesicle is being formed, then it is interiorized inside the cell. So this is the process of pinocytosis. So polypeptides like insulin cross the blood-brain barrier by this process, that is pinocytosis. Then anti-tumor drugs present in liposomes are also transported by this mechanism. Pinocytosis cannot transport a large quantity of drug because then the number of vesicles which will be required will be beyond the capacity of the cell, because the number of vesicles which can be formed is limited, so pinocytosis cannot be used for the transport of large quantities of drug. Now coming to the next process, that is phagocytosis. So in phagocytosis, the particulate matter, that is the drug, is transferred by local invagination of the cell. So it is very much similar to pinocytosis. There is a small difference between pinocytosis and phagocytosis, that is in pinocytosis the solution which contains the drug is being engulfed, whereas in case of phagocytosis, the solid particle, that is the drug, is being engulfed by the invagination of the plasma membrane, that is it forms a pseudopodium, and finally a phagosome is formed, that is the food vacuole. So poisoning by botulinum toxin is an example of this type of absorptive process. This is phagocytosis and this is pinocytosis. Here you can see the solution with the drug, and here you can see directly the solid particle. Now next process is called as filtration. So in this process, the free or unbound drugs of smaller molecular size can pass through the pores or spaces which are present between the cells. So here you can see the drugs are being filtered out from the spaces or the pores which are present in between the cells. So this process is called as filtration. So it is a physical process, and the rate of filtration is actually proportional to the pressure gradient. That is the pressure gradient between the exterior and the internal environment, that is inside the blood vessel and outside the blood vessel. So example of the drugs which follow this transport mechanism includes alcohol, glucose and urea, which is being filtered through the glomerulus. Now coming to the absorption of the drugs from the various sites in the body. So first is the absorption of the drug from GIT. So most of the drugs from GIT are absorbed by passive diffusion. Some smaller drugs get filtered through the pores in the cell membrane, and sugars are absorbed by active transport. So non-ionized lipid-soluble drugs are absorbed better, and this is because the non-ionized lipid-soluble drug can easily cross the cell membrane, that is which is made up of the phospholipid bilayer. Next is P-glycoprotein, which is present in the enterocytes. P-glycoprotein, remember, it is responsible for efflux in the efflux of the drugs which is present in the enterocyte. Then we have vomiting, then we have diseases of GIT and metabolism of drug in the liver, which compromise the absorption of the drugs from GIT and also hence decreases the bioavailability of the drug. So these are the factors, that is P-glycoprotein which is present in the enterocyte, then we have vomiting, then we have diseases of GIT, then metabolism of the drug in the liver, which is actually not a part of the absorption, but all this leads to decreased bioavailability. Now first, the absorption of the drug from mouth. So the lipid soluble basic or neutral drugs are absorbed from mouth as the pH of the stimulated saliva is alkaline in nature. An important point which we have to remember here is when we are giving a drug via mouth, that is we are giving a sublingual drug, the sublingual absorption of the drug actually bypasses the first pass metabolism which occurs in the liver. So hence it increases the bioavailability of the drug which is given by sublingual route. Example is sublingual isosorbate dinitrate for angina, that is chest pain. Then coming to the absorption of drug from stomach. So the lipid soluble acidic and neutral drugs are absorbed as the stomach pH is acidic. The drugs absorbed enter the hepatic portal system and they undergo first pass metabolism. Now the absorption of the drugs from the small intestine, that is lipid soluble basic and neutral drugs are absorbed from here, example morphine, and intestine is the major site of absorption for most of the orally administered drugs because of its larger surface area of absorption, and the drugs absorbed from here enters into the hepatic portal system just like it is being entering into the hepatic portal system in case of the absorption from the stomach, and then it will undergo first pass metabolism in liver. Now the absorption of the drug from large intestine or colon. So the lipid soluble basic and neutral drugs are absorbed as the pH which is present inside the large intestine is alkaline. Major amount of drugs are directly entering into the systemic circulation because of the presence of external hemorrhoidal vein. Hence there is minimal first pass metabolism out of these three, that is via stomach, via small intestine and via large intestine, because here we have the external hemorrhoidal vein, and because of the presence of the external hemorrhoidal vein, some of the drugs, that is 50% of the drugs, will skip the first pass metabolism when it is being absorbed from large intestine, but the absorption may be erratic from large intestine. So the rate of absorption from fastest to lowest is seen in case of sublingual route, following that we have the rectal route, and finally we have the oral route, because in oral route there is maximum metabolism plus there is also delay in the absorption. Now coming to the absorption via the parenteral sites. So parenterally we can give the drug either by intramuscular route, then we can give by intravenous route, then we can give by subcutaneous route. So drugs which are injected intravenously, they are bypassing the absorption as they are actually directly entering into the bloodstream, because the definition of absorption is what? It is the entry of the drug into the bloodstream. So in intravenous route of administration, it is directly entering into the bloodstream, so it has completely bypassed the absorption process. Next is absorption following IM and SC, that is intramuscular and subcutaneous injection, usually occurs by passive diffusion from injection site to the plasma, and absorption following intramuscular injection is comparatively faster than the subcutaneous injection because of the increased vascularity of the muscles. Now coming to the next method, that is absorption via the lungs. So drugs like general anesthetics, then we have salbutamol, that is beta 2 agonist, then we have disodium chromoglycate, are absorbed by simple diffusion from the pulmonary epithelium, that is the epithelium which is covering the lungs, and absorption is rapid because of the larger surface area and high vascularity of the lungs. And here also the first pass metabolism is bypassed. Now coming to the absorption via the topical sites. So absorption through intact skin is usually poor because epidermis acts as a barrier and the underlying dermis is vascular. So the lipid soluble drugs are usually absorbed from the underlying dermis. Then the absorption is actually better from the abraded skin. This is because the barrier, that is epidermis, is not present in case of abraded skin. So this will actually facilitate the absorption of the drugs. Now absorption from mucous membrane is even better than that seen with the skin. This is because it is thin and it is highly vascular. Example, we are having oxytocin and vasopressin nasal spray. Then ophthalmic drugs are given, that is in the form of eye drops and ointment, and they are being absorbed from the cornea and conjunctiva. Now coming to the methods for delaying the absorption of a particular drug and methods for facilitating the absorption of the drugs. So methods for delaying the absorption of the drugs, we can use an appropriate dosage form. So slow but sustained release forms can be used, like we have the retard tablets, then we have the spansules, example iron formulations, then we have the depot injections, example testosterone, and then we have flufenazine depot injection, and then we have subcutaneous implants, example testosterone pellets. So these will actually provide a sustained release of the drug, but it will delay the absorption. Next is we can change the physical characteristics of the drug. So insulin zinc amorphous suspension, which is also known as semilente, is absorbed relatively faster than insulin zinc cloudy suspension, which is also known as ultralente. So this is because of the variation in the physical characteristics of the drug. Next is we can apply a tourniquet, or we can add a vasoconstrictor drug like adrenaline to a solution of xylocaine, which is a local anesthetic. By both these methods, what we can do is we can prolong the local anesthetic effect of the local anesthesia, that is xylocaine, and we can delay the systemic absorption and hence the systemic side effects of the local anesthetics. So this is the reason why in shock there is decreased absorption, because in shock we have decreased peripheral blood flow. As a result, the absorption is being delayed in case of shock. Now coming to the methods for facilitating absorption. So adding hyaluronidase to the injection fluid will actually increase the rate of diffusion to the interstitial spaces, and as a result it will enhance the absorption. Next is by doing hot fermentation or massage, we can increase the local blood flow. So this increase in the local blood flow at the site of injection will also facilitate the absorption. Coming to the next term, that is bioavailability, which is a very important term. So it is the rate at which and the extent to which the unchanged concentration of the drug is available in the systemic circulation. That is what we call as bioavailability. So the important points regarding bioavailability is that when we give a drug by intravenous route, it is having 100% bioavailability because the drug directly enters into the bloodstream, and sometimes the bioavailability of intramuscular and subcutaneous route are almost close to each other, and they are also close to that of IV. But if the drug precipitates in the tissue, like in case of the drugs like digoxin, then we have phenytoin, then in that case the bioavailability via the intramuscular route and subcutaneous route will decrease substantially as compared to that when the drug is given by IV route. Now next is bioequivalence. So if two or more similar dosage forms of the same drug reach the blood circulation at the same relative rate and to the same relative extent, then we can call them as bioequivalent preparations. That is, same relative rate to which it is reaching the blood circulation and same relative extent, that is extent and rate of reaching into the circulation. The differences of less than 25% in the bioavailability among several formulations of one drug will usually have no significant effect on the clinical outcome, and hence such formulations are also bioequivalent. That is, differences which are less than 25% of bioavailability, in that cases also both the formulations are bioequivalent. The differences in bioavailability of different formulations of a same drug is a huge concern for the drugs that show a steep dose response relationship. Example, the drugs which are having zero order elimination kinetics like phenytoin, warfarin, and with drugs which are having narrow margin of safety like we have theophylline, then we have antiarrhythmics and cyclosporine. So in these cases the patient should be stabilized with one brand formulation and it should never be changed unless the changed brand is bioequivalent to the previously used one, because this will lead to either therapeutic failure because of the decrease in the bioavailability, or it can actually lead to drug intoxication, that is toxicity, because of the increased bioavailability. So it is always better to be stabilizing a patient with one particular brand formulation. Now coming to the other different types of equivalences which are present. First is chemical equivalence. If two or more dosage forms of the same drug contain the same labeled quantities of the drug, then they are chemically equivalent. So two brands of drugs may be chemically equivalent but may not be bioequivalent. Next is pharmaceutical equivalence, that is if the two drug formulations of the same active drug entity also contain other similar ingredients like excipients, then they are pharmaceutically equivalent. Next is therapeutic equivalence, that is two brand products of one drug are therapeutically equivalent if they provide an identical in vivo pharmacological response as measured by the control of the symptoms or a disease and safety profile. Then we have clinical equivalence, that is if one structurally different drug can provide the same clinical response as that of the another drug, then they are clinically equivalent. Now coming to the measurement of bioavailability. So the three important parameters which are being considered includes the peak plasma concentration of the drug, which is also known as Cmax, as you can see here. Then we have the time to attain the peak plasma concentration, which is known as the Tmax. Then the area under the curve of the plasma concentration versus time curve, that is the plasma concentration versus the time curve. So these are the three important parameters which we'll look into while doing the measurement of bioavailability, that is the maximum drug concentration, then the time taken to reach the maximum drug concentration, then area under the curve. So Cmax and Tmax are actually the indicators for rate of absorption of the drug, and increased rate means a higher peak at a shorter time. And AUC actually represents the extent of the absorption, that is extent of absorption means the total amount of drug which has been absorbed into the circulation. So Cmax and Tmax indicates the rate and AUC indicates the extent of absorption. So AUC is a better index compared to Cmax and Tmax for bioavailability of the drugs which are to be given for a longer duration. Now coming to the different methods of measuring the area under curve for knowing the in case of the bioavailability. So we can use a planimeter, that is you can see here the planimeter is an instrument which is used to measure the area of the plane figures, as you can see here. Then we have the cut and weigh method, where we cut the AUC curve and we measure its weight on an analytical balance. So this is another method. Then we have the trapezoidal rule, that is in which the area under the curve is divided into several trapeziums, then the area for the several trapeziums are found out, and then we finally add up those areas. So these are the three different methods by which we can measure the area under curve for the bioavailability graph. Now calculation of the bioavailability of any oral dosage form is being given by this formula, that is the drug bioavailability is equal to AUC for the drug which is given by the oral route by AUC for the same drug which is given by the IV route into 100. So this is the formula for the drug bioavailability of a particular drug, that is the oral dosage form of that drug. Now coming to the factors which are influencing the absorption and bioavailability of the drugs. So these factors can be broadly classified into pharmaceutical factors and pharmacological factors. Now we will be discussing these two factors separately. First, coming to the pharmaceutical factors. So on oral administration of a particular drug, two processes actually precede the actual absorption of the drugs. So the first one is disintegration, that is disintegration of the solid dosage form of the drug into fine particles. So hard tablets take more time to disintegrate compared to the ordinary tablets. So this is the one which affects the disintegration process. And then we have the second step, that is dissolution. That is dissolution means the dissolution of the active drug from fine particles into the solution. So whenever we administer a drug in solution form, it saves time because we are actually bypassing both the disintegration and the dissolution process because it is already present in the solution form. Now coming to the various pharmaceutical factors which are affecting these steps, that is mainly the disintegration and dissolution, because these are the rate limiting steps in the process of absorption. First is particle size. So a drug dissolves rapidly when its surface area is increased by decreasing the particle size. That is why poorly soluble drugs are marketed in finely particled form. Example, microfine aspirin, microfine glycofulvin. Then we have the salt form, that is salts of weakly acidic drugs are highly water soluble. So weakly acidic drugs are given in the salt form, that is to facilitate faster dissolution and absorption. Example, we have phenytoin sodium and then we have the tolbutamide sodium. Then we have the next parameter, that is the crystal form. So amorphous forms of the drug are having faster dissolution as compared to the crystalline form. So we are always preferring the amorphous form, that is amorphous chloramphenicol palmitate. Then we have water of hydration, which is another factor. So many drugs can associate with water to form the hydrates, that is the hydrous form. So the hydrous forms have slower dissolution rate as compared to the anhydrous forms. So we are preferring anhydrous forms because they are having a faster dissolution rate, anhydrous forms of theophylline and ampicillin, which will facilitate the absorption. Now continuing with the pharmaceutical factors, coming to the next point, that is the nature of excipients and adjuvants. These are pharmacologically inert substances which are added to a drug as a filling material or a binding agent. Example, we have starch, then we have lactose, then we have polysorbate 80. So these have a huge effect in the bioavailability of the drugs like phenytoin, levodopa and digoxin, because some of these drugs are actually wetting agents like lactose and polysorbate 80. So what they will do is they cause the solvent penetration into the drugs. Because of the wetting property, the solvent gets penetrated into drugs and as a result there is a faster dissolution and absorption. So this can sometimes even lead to drug toxicity when the plasma concentration of the drug increases very fastly because of the faster absorption. The next factor is degree of ionization. As we know, non-ionized lipid soluble drugs are better absorbed, whereas strongly acidic or basic drugs or highly ionized drugs have decreased bioavailability from the gut because of their ionized form, which is less lipid soluble. Example of the drugs are streptomycin and neostigmine. Now coming to the pharmacological factors which are affecting the absorption and hence the bioavailability. First is gastric emptying and the gastrointestinal motility. So faster gastric emptying helps the drug reach the intestine faster and as a result it increases the rate of absorption. Then we have gastric emptying is being actually promoted by fasting, anxiety, then the person lying on the right side, then we have hyperthyroidism, and when the person is given several gastrokinetic drugs like metoclopramide. And this gastric emptying is actually retarded by some other factors like fatty diet. Then we have endogenous depression if the person is lying on the left side, if there is pyloric stenosis, if the patient is having hypothyroidism, or if the patient is given drugs like atropine and chlorpromazine. So in that case, it will decrease the gastric emptying, and the other factors like hypothyroidism and all, which I have already mentioned, will increase the gastric emptying. That is, it will make the gastric emptying faster. Next is gastrointestinal disease. So in diseases like celiac disease, there is decreased absorption of antibiotics like amoxicillin. So this amoxicillin is being absorbed less in case of celiac disease. But on the other side, in celiac disease, there is increased absorption of other antibiotics like cephalexin, and celiac disease is not having any effect on the absorption of antibiotics, that is ampicillin. So some of the antibiotics in case of celiac disease will be absorbed faster, some of them will be absorbed slower, and some of them will not be affected by celiac disease. And in case of gastroenteritis, there is decreased absorption of all the drugs which are given by the oral route. This is because the gastric epithelium is affected. Now the next factor is food and other substances. Generally, gastrointestinal absorption is favored in case of an empty stomach, but in case of the drugs like griseofulvin, its absorption increases after a fatty diet, and iron absorption, it increases in the presence of vitamin C. So these are the areas where the food and other substances can also affect the absorption of the drug which is given by the oral route. Now next is the first pass effect. So this is actually not affecting the absorption as such, but it affects the bioavailability because it causes the metabolism of the drug. So first pass effect is nothing but the drug degradation which occurs before the drug enters into the systemic circulation. The net result of the first pass effect is decreased bioavailability. Thus, bioavailability of the drugs like nitroglycerin, morphine and propranolol is less if it is given by the oral route because of the significant first pass effect. I'll repeat it once again. First pass effect is actually not affecting the absorption process, but it is affecting the metabolism, and hence it affects the bioavailability because bioavailability depends on both absorption and metabolism of the drugs. Now coming to the next factor, that is drug-drug interaction. So liquid paraffin decreases the bioavailability of the fat-soluble vitamins as it emulsifies the fat and therefore causes deficiency of fat-soluble vitamins like vitamin A, D, E and K. And then next we have antacids which cause reduced bioavailability of the tetracyclines because antacid contain aluminium, calcium and magnesium, and hematinics contains iron. So they cause the reduction of the bioavailability of the tetracycline. This is because the chelated complex is being formed and it is poorly absorbed because of the chelation with the other components, that is aluminium, calcium and magnesium, which is present in the antacids. Next is barbiturates. They reduce the bioavailability of the several drugs because of the enzymatic induction. So again here it is not affecting the absorption process, but it is affecting the metabolism process. Next is probenicid. It blocks the penicillin excretion and as a result it increases the bioavailability of the drug. So here also it is not affecting the absorption process, but it is affecting the excretion. So when excretion is affected, this also actually affects the bioavailability of that particular drug. Coming to the pharmacogenetic factors, so in this we have slow acetylators of isoniazid. So slow acetylators of isoniazid actually show increased bioavailability and therefore are more subjected to isoniazid induced neurotoxicity. That is a side effect of isoniazid. And then we have another example, that is people with atypical plasma pseudocholine esterase. So people with atypical plasma pseudocholine esterase, which is actually having a very low hydrolysing capacity of succinylcholine. For them, only 1/6 of the normal dose of succinylcholine is required because the hydrolysing power is very low of the atypical plasma pseudocholine esterase, and if we give a normal dose that is more than 1/6 of the dose, then it can lead to a condition which is also called as succinylcholine apnea. Then finally, we have miscellaneous factors like the route of administration of the drug. Then we have the state of circulation in which the individual is present, like the shock state. In shock, there is decreased blood flow. As a result, this affects the blood. As a result, this affects the absorption and also it affects the bioavailability. So these are the miscellaneous factors which also affect the absorption and bioavailability of the drugs. So finally, coming to the references which I have followed here. So this includes the book of K.K. Sharma, and we also have followed Goodman and Gilman. So with this, I would like to end this presentation. I hope you like my content. If you like my content, then please do like, share, subscribe and comment, and also press the bell icon to get notified whenever I upload a new video. Thank you guys.